I started.
All right. So the ECG itself, electrocardiogram, it's a recording of the electrical activities occurring there in the heart. In the previous classes, we've talked about, I'm talking about the physiology class we held 2 weeks ago or last weekend. We talked about depolarization, repolarization. We talked about the conducting system, that's from the SA node to the AV node, down to through the bundle of his and Purkinje fibers. Those are the electrical activities of the heart. And on its own, the heart can generate that impulse for it to help with the contraction. So it doesn't really need the brain, so to speak. That's why I told you the heart is the last organ to die. Once the heart is not functioning, then the whole body system is gone. So that is what the whole heart is all about in relation to the electrical activity. So that's just a way of introduction, bringing in what you know into what we'll experience today or see. So going by this outline, we'll just briefly go through all of this as fast as we can and as much as we can cover. Like I said, it's not just about crop. However, you still see most of these things relating to crop. Ideally, today we're supposed to take the parts anatomy, but then there are still questions um, under pathophysiology that have to do with ECG, that have to do with the conducting system and all of those things. So since I promised some months ago that I was going to take the ECG class, I decided to bring it first and then we'll continue with our croc subjects. And then that's why I decided to make this open for everyone who is on the group chat and not just strictly for those that have subscribed for this plan. So yes, we have the introduction, we have standardization, the speed reading, rates, complexes, axis, and then conclusion. So before I start, I'll give credit to one of my colleagues here, Dr. Princess, who I got this um, notes from. So I took the consent from her. I'm going to use it for my explanation here. So by way of introduction, the electrocardiogram is a simple painless test that measures the heart's electrical activity. So it is simple and it is painless test that measures the activity of the electrical activity of the heart, like I said. I remember then when I was in Sumdo, we used to have the practical session before the whole COVID and the war. We used to have the practical session with our internal medicine teacher there. And yes, we'll use one of us as the patient in quotes. We'll put or place those leads, the chest leads and the hand leads and all of those things. That's where the ECG tracings are gotten from, and then you see it calibrated on the graph. However, um, in some developed countries and modern means of modern medical, which is you can have these ECGs on the monitor. You don't need to print out the graph and start reading it out. Everything will be there on the monitor, which means you can send it as an email to the cardiologist. Now, it is important for you to note that these ECGs, uh, we don't really, even up to the postgraduate level, sorry, up to the end of MBBS level, that's the 6th year, we don't really go deep into ECG. It is normally left for the those want to specialize in cardiology or thoracic surgery. So those are the people that actually dwell on this ECG. So there are a lot of things. There are some deep concepts which might not be of interest to you, but however, you just need to understand them. Because like I say, you know where you find yourself tomorrow as a practicing doctor. So it is also known as ECG or EKG. It depends. You know how this German English pronunciation or Russian English pronunciation key is C in some of these places. So ECG, EKG, however you see it, is still the same thing. But the pronunciation is electrocardiogram. That's the full. So this is a typical picture of an ECG graph. This is a typical picture of an ECG graph. You have various features here. Here you can see lead one, lead two, lead 3. You can see V1. You can see AVR. You can see AVL. You can see AVF. You can see V1, V2, V3, V4, V5, V6. So don't worry. At least by the end of this class, by the end of this session, you will have an overview, a better understanding of what all of these mean. So let's continue. Let's go ahead. First of all, you need to understand that in the normal ECG, what you have is, this is what you have normally. This wave you are seeing here. Normally, I draw it in our class sessions. You see me draw something like this, roughly, just a rough sketch. Sorry, something like this. I put it this way normally, and then I do like this. This is P, Q, R, S, T, and then sometimes U. So that's typically what you are seeing here. This is clear. This is printed, so it is clear enough that you have the P wave, you have the Q, R, S, and then T wave. So all of this is normal tracing of the ECG. It is called the ECG tracing. ECG tracing. So this aside, I've also taken my time to explain what each of these tracing mean. I've told you that the P wave is what? The depolarization of the atrium. So that's what you can see under here. Depolarization of atria. Atrial depolarization, that is the two atria, I mean. And then you have depolarization of the ventricles, which is QRS complex here. And then next you have repolarization of the ventricles. So by way of revision again, I have drawn something like this. Excuse me. And we'll have something like minus 90 here, minus 70, and then we'll have 0, and then we'll have plus. Okay, let me take it up there. Plus 30 as the highest. This is millivolts on the y-axis. While here on the x-axis, we'll have time. That's in seconds. Not 1, 2, 3 actually, but it's in 0.00 and all of those things. But just know this is time in seconds. So, however, what you need to understand from here, I'm just trying to bring the concept of depolarization and repolarization back into this ECG, because the whole thing relates to the heart itself, although it is plotted on the graph. So I've told you in some text, you'll see minus 70, Cron uses minus 70 as a starting point. And then from minus 70, depolarization occurs, and the maximum is plus 30, and then there's repolarization. So here, what happens is that, let me zoom this a bit. What happens here is that sodium is coming in. This is depolarization. Depolarization. And it's because what sodium is coming in, that sodium influx. It is one of those questions I asked in last week's quiz. This is sodium influx. That means there's sodium coming into the heart. You've been hearing me saying influx, or coming in. That means this is sodium coming into the heart. And then there's what? Repolarization. Repolarization. It is due to potassium leaving. That is efflux. So potassium is leaving the cardiac cells. But then you can have hyperrepolarization. You can have this is the baseline, which is 70. But then you can have it going exceeding 70, reaching down to minus 90. So in that case, that means let me use the blue color here once more. Here. Down, you can have it as hyperrepolarization. Repolarization. And this is, since since potassium leaving causes repolarization. Now, when there's excess potassium leaving, then that is what causes the hyper repolarization. So I'm just trying to bring this back to revise with you all those concepts of depolarization. And when you say depolarization, it is contraction. When you say repolarization, it's relaxation. I mean, that's the aftermath effect of this depolarization and repolarization. It is contraction and relaxation. So the same thing here. You have the P wave. If you see P wave here, tracing it down is what depolarization of the atrium. So the activity of the P wave on the ECG relates to the heart, which means there's contraction of the atrium or depolarization of the atrium. So that's when you see P wave. Yes, you see that there's P wave, and then you can see, yes, there's actual contraction of the atrium. When you see QRS complex, it means there's depolarization of the ventricles. You know, the heartbeat, the heart movement is, this is a rough sketch of the heart. This will contract first, which I told you also last class, while this is simultaneously relaxing. That's the ventricles down there, those lower chambers. Then the opposite will happen next. The atrium will then relax, and then the ventricles will contract. So that's how the heart pumps out the blood to the different chambers and also to the different chambers and to the body system in general. So that aside, we've gotten the concept of PQRS complex. Then the T wave now is repolarization of the ventricles. That means the ventricle is now relaxing. But there are some other features in between all of these. That's how we'll have the interval, PQ interval, we'll have ST interval, and all of those things. We'll look at them briefly too. But this is just the basic concept. Once you understand this, you can use this as a yardstick, a landmark towards other features. All right. So when you pick an ECG graph, an ECG paper, there are some things you need to take note of. Now, I'm not explaining these things to you, you being a student. I'm explaining these things to you, taking you as doctors already. So not just carrying it and then answering exam questions. No, not just picking it and answering exam questions. No, but in this case, you are picking a patient's ECG and trying to analyze. So the first thing you do, ideally, which is the basic principle, and what you are supposed to do is you check the following details. First of all, you check and confirm the name. These are common errors made in practice. Not just ECG, even lab reports and all of those things. Yes, we are seeing the patient and then they bring in. Some attendants might make some silly mistakes, and then they bring in someone's folder, and then you begin to attend. You've not even confirmed the patient's name and details, and then you begin to answer or reply to the patient. We've heard of cases, although I don't know if it's just stories that have been told fictional, but then we've heard of stories that, well, because there was no proper review, the patient that was supposed to, I think he had prostate cancer, but then the doctor mistook the case for a patient that was coming in for amputation, and that's how his limb was amputated. And well, the patient was on anesthesia, general anesthesia, so he was not able to tell whether that was his issue until after the whole thing was reviewed. And you know, we have medical legal practice, that is bringing in legal practices or legal investigations into the medical practice. They will sue you, and then before you know it, the whole thing will be against you. Then your license will be seized. So all of these things are very important. You confirm the name and date of birth on the ECG. It will be there on the ECG clear for you, and then you confirm with the patient if it matches. So that's the first thing. Once you're done with that, then you check the date and time the ECG was performed, because in trying to analyze the ECG, maybe the patient has come with complaints, and then you're trying to analyze, okay, when did this condition start? If it was done after an ECG was taken, maybe it was a referral to your hospital, you check those details, sorry, and then try to confirm, okay, this has been a long time compared to when this condition started. This is a recent condition, so you might as well want to take another ECG on that patient. If it's most recent, then it is not an issue. Or if the ECG taken comes after the patient's history of of complaints, presenting complaints, then there's no need. So also you check the calibration of the ECG, that is standardization and speed, which I will explain briefly below. So for the standardization, all these things are just, of course, most because of your busy schedule and you're all about trying to find out the diagnosis. Most people don't actually do all these things, but ideally you are supposed to check and confirm all of this. So for the standardization, this simply means that for the normal ECG, first of all, there are 10 small boxes vertically. You have to confirm that, yes, there are 10 small boxes vertically. And then each of these boxes, sorry, in total, this box is 10 millimeters by measurement. So you just confirm by reading the counting number of boxes, I mean. So that's enough. Then if the voltages are very high, you can then use half, that is small boxes of 5 millimeters. I'll show you down very quickly what I'm trying to explain here. And then if the voltages are very low, you can double it and use 20 millimeters. So this is what I'm talking about. When you pick the ECG itself, first of all, one small box. Okay, you should note first of all that you have these small boxes this way. You have another one, 2, 3. That is the first thing you should note here on this ECG graph. Secondly, you should note that yes, you have 5 here, you have 5 here, but this as a whole forms a bigger box for the ECG. So when you pick this ECG graph, what you need to confirm is these boxes now. Are they up to 5? Yes. The small boxes in this big one, are they up to 5? Vertically, yes. 1, 2, 3, 4, 5. And horizontally, are they up to 5? Yes. 1, 2, 3, 4, 5. So you've confirmed that. However, when you're talking about the big long box, that means 2 of this. 2 of this one, which is what you can see here, is going to give you 10. And by way of measurement, this is what you have. What I just said earlier, what is written here ideally. The small box is what? Is 0.1 millivolts. As it's going up, remember that millivolts per time I described. This is millivolts. This is time in seconds. So the voltage in millivolts is, as you're going up, this box is 0.1. The second one is 0.1. The third one is 0.1. The fourth one is 0.1. The fifth one is 0.1 again. And then in measurements, it is 1 millimeter. So this is for the small one. The big one, you can see it if you're just trying to estimate for this big one is 0.2, 0.2, 0.2, and then 5 millimeters. And then for the 10 boxes, which is 2 of this here, 2 of this, which is what you have here, then it is 1 millivolt completely. So all of this aside, just a way of introduction, also trying to get you to understand these readings. However, this is not really important for bringing out diagnosis. This is just for you to understand what the ECG paper is all about. Then the second thing is, that was standardization. The second one is speed. The speed, like I told you, is on the x-axis. That's the horizontal axis this way. And the normal speed of the ECG paper is 25 millimeter per second. So what this means is that on each small box, you have 0.5. No, sorry, on each small box, you have, okay, yes, you have 0.25, 0.04, sorry, I mean, here it is, 0.04 on each. When you multiply by 5, then you have about 0.2, you have about 0.2, yeah, about 0.2. Or however, that's still by the way. So this is the box here. This is the picture, I mean. This is a small box. Yes, this is a small box. You know, this whole box here having 5 horizontal, 5 vertical is what is being shown here. And on this small one, it is written here that is what, 0.04. So on each of this small box inside here, you have 0.04, 0.04. And then if it's the whole 5 here, then you have 1 second itself. on one large box, you have 0.2, I mean, which is times 5. 0.04 times 5 is 0.2. So you have 0.2 here. All right. So the measurement is 10 millimeters if you're going this way. However, that's the length. However, that is covering 2 boxes, but for one box this way, or this itself is 0.5 millimeters. So, well, that's just speed, that's just standardization. But like I said, that's just to put that aside. Now, the main thing here, this is where you lay your focus on as a clinician, because we have a specialty which is called, well, it depends on your country or your region, but here I think they call it medical technicians that can analyze all of those things in details. Yours is to make the diagnosis. So this is where your focus should be from this page I'll try to explain. So we have what we call the reading. The rhythm, just like you have in music, the rhythm is the way the melody goes in music. So also the rhythm in the heart or conductive system of the heart is the way this heart electrical activity go, the pumping activity, and all of those things. So you can have sinus rhythm. Sinus rhythm is termed normal rhythm, and the sinus arrhythmia is termed abnormal. This is normal. This is abnormal. The sinus there is just, it doesn't really mean anything, but just telling you, you remember ECG, sorry, the heart, the SA node is one that generates that impulse, which is around here on this part of the atrium, and then transfers it to the AV node. So this SA node in full is called sinoatrial node. It's called sinoatrial. So that's sinoatrial, that's where the word sinus is coming from. So that's just what sinus is, how sinus is being attached to that rhythm there. So yes, it is coming from the sinus. The rhythm is coming from the sinus, sinoatrial actually. So just like you have uh, in common English language, you have, when you have the word typical and you have atypical, this means the opposite, or absence. This means absence. So it's the same thing here. It means that there's absence or abnormal reading. That's why you have arrhythmia. But reading is the normal, arrhythmia is the abnormal. So what do you have when you have sinus reading? That's in the normal ECG, in the normal heart, I mean. An ECG is in sinus reading if every P wave is followed by QRS complex. Every P wave is followed by QRS complex. Like I always draw, this is P. Okay, this is not writing down there. All right, so this is P. Then you have Q, you have R, S coming this way, and then you have the T. So it means that this P is always followed by Q, R, S. You shouldn't have P and then you should have T next. No, it must follow. After P, you should have a QRS complex. That makes it a normal or sinus reading. That's the first concept, first criteria here. So the second criteria is what? RR intervals must be equidistant. You know, this is a cycle, right? P, let me draw it here. P, Q, R, this is rough. P, Q, R, S, T. After this T, well, in pathology, you will have U, but we're talking about a normal ECG here. So after this U, after this T, I mean, you'll have another P, Q, R, S, T. Then you'll have the next one. So this is R up here, and then this is R again. It means that this distance between each of the cycles should be the same for throughout the ECG reading or ECG waves. It should be the same. The distance have to be the same. So those two criteria P wave followed by QRS complex, which is 1. Secondly, RR intervals must be equal in distance. So that is what makes it sinus reading. That's a normal ECG for you. Now, however, when you're talking about arrhythmia, P waves must follow QRS complex exactly just as you have in sinus reading, but the RR intervals will vary. Now you can have RR intervals being shortened. This is 1R. Then the next R is here. And then the next R is with the distance, which is here. And then the next R again with another distance is here. So you can see that this distance vary. This is short, this is long, this is longer. So that is what the sinus arrhythmia means. But however, the QRS complex must follow after the P wave. Are we together? So in this picture, we can still have an idea from here too. We can pick it from here. Sinus reading. This is normal sinus reading. You can see at this distance. You can, if you want to count the boxes, fine, but well, by estimation, you can see at this distance are the same. First of all, the P is here. Then this is the QRS. Then you have another P. Then this is followed by QRS. So that's your first criteria. P again, QRS. This is normal. Then secondly, the distance are the same. The distance are the same all through. But then when you come to the sinus arrhythmia, which I just explained here, yes, you have the P wave, which has to follow the QRS complex. Let me zoom this. I think this is quite blurry. So what you have here, you can see this distance from here to here, that's RR. This distance looks longer, of course. It varies now. This one also looks much longer. And then this one looks shorter again. You can see. Then this looks a bit longer again. So this is the variation we're talking about. That is sinus arrhythmia. So that's a difference. Are we together so far?
Please, can you repeat this?
Any confusion?
Explanation.
Sorry, the sinus reading.
The abnormal one, yeah.
Which one? The abnormal one. Okay. I told you in both cases you have to have P wave and then QRX following next. But then for the normal one, you have the interval between R and R being the same. There's no change at all. But in the arrhythmia, you have a variation. There is a change between the R and R. This R here to here is looking shorter. Here to here is looking longer. Here to here is looking much longer. Here is shorter again. You can see the variation. Do you understand that?
Yeah.
Yeah, here is looking shorter again. But let me erase this so that you observe by yourself. It will be clear enough for you to observe. So you can see this is long, this is short, this is quite short again, this is long, they're just variations. Remember, this is R, this is another R, the whole cycle, this is another R. So it's the RR interval we're talking about here. That makes it different from sinus reading. In sinus reading, the RR interval are the same. You can see there's no change. It's still the same length. If you want to measure, count the boxes, you'll see that it's actually the same. So when you pick the ECG, first of all, this is the first thing you should note. By the time you see that the RR interval is changing, then you should know that there's a condition. So that's the first step. You will check the RR interval. If there's now a variation, then you say, okay, yes, there's actually a pathology in these patients. But however, you won't stop there. There are other features too you'll find. But this is the major thing that will give you a hint towards knowing whether there is a condition or not.
All right.
All right. So there's what we call the rate also. Just like you have heart rates, that is what you have here. You know, all of these things we measure, we use machines to measure this, or you can count the pulse, the radial pulse, the femoral pulse, popliteal, carotid pulse, and all of those things, or brachial pulse. But this is now bringing what you actually do into practice, like how those values are being gotten. So by the time you count the number of big squares between the R and R interval in a normal ECG, you divide it by 30. That's the first way of getting your rate here. Or you count the number of small squares in between the R and R and use it to divide by 1,500. So even if I don't see the patient, but I have the ECG will tell me everything about the patient's condition concerning his heart or circulation, heart and circulation, that's blood circulation. So, the pulse, practically, you can use the machine, the pulse oximeter, you insert it on the finger, or you can use the manual method. You place your index and middle finger on the radial, what do you call that? That's the most distant part of your radius, the bone radius on the wrist, around the wrist. That's how you check for pulse. You also check at the carotid, that's on the neck. So by the time you place your finger, you count the pulse per, but that's manual. So if I have the ECG without seeing the patient, I can still know his pulse by what? Counting the boxes between the RR interval. These boxes here, between the RR interval. And then by the time I count the boxes, the 5 big boxes, I mean. So, okay, I mean the 5 big boxes or squares. So we'll have 1, 2, 3, 4, 5. And then by the time I divide this, I divide it 300 divided by 5. That will give me something like that's 60, right?
Yeah.
300. Here I counted 5. That's what I'm saying 5. 1, 2, 3, 4, 5. 1, 2, 1. It starts from here. 1, 2, 3, 4, 5. Also 1. So for the normal over 5, that's where you have 60. And if you remember the normal hearts, 60 beats per minute. The normal value for heart rate is, or pulse rate is the range of 60 to 100 beats per minute. So even if it's expanded and then you have maybe a 6th value, if you divide, no, not a 6th value, you have it less, you have maybe 300 divided by 4, it will give you a bit higher than 60. But so far it is within this range, then it is normal. So that's the calculation. Or the second method is what? To count the small squares, which is going to be stressful. Imagine all these squares in between you're counting. So just better you go for you hold one of the methods. You mustn't know the two. Just hold one of the methods and then you use it. You'll be good with it. And which I would advise for you to go with the big squares and then divide by 300. 300, so divide by the big squares. Yes?
So we do 300 divided by
Yes.
I don't know.
Yes, 5, which is 5 big boxes.
Okay.
Yeah. Just for you to remember, these are the big boxes here. You have 1, 2, 3, 4, and then 5. It mustn't be complete, but so far it approaches a new box, another box. Then it is giving. I remember this is not like the digital method of checking the pulse rate, because digital will give you the actual value. So because of this half on this 5th one, it is ideally supposed to be something like 300 divided by 4.5, because this is like half. But well, we'll just estimate. Everything's about estimation here, so we'll just use the 5 here. But that's how we'll have a range. So it should fall between a 60 to 100 beats per minute for the pulse rate. So if you're counting the small boxes, then it should be 1,500 divided by the number you get, which is, I can't remember the number you get, but if you have an ECG and you check, you can estimate that. So like you can see here, the normal is 60 to 100 beats per minute. That's a normal pulse rate you have for everybody. So when you have abnormal pulse rates, then you can start thinking of some other things. So the first thing I told you is, after you've confirmed that the QRS follows the P wave. Now I'm trying to help you picture this. You don't have the patient with you. You only have the ECG with you, ECG graph of a patient. But all of this information can tell you everything about the patient. So after checking, confirming that the QRS follows the P wave, And then next, you count the number of boxes and then you determine the heart rate of the patient. Yes, maybe it can be normal. That's for the QRS complex following the P wave and all of those things. But then by the time you divide this and then you find out that there is a deviation from this normal 60 to 100, then it can suggest something else. Now, when it's lower than 60, it is what? Bradycardia. When it's higher, it is tachycardia. Bradycardia means there's less heart rate. And then tachycardia, there's increased heart rate. And relatively, that means there's increased pulse or increased cardiac activities. These are all features of different heart conditions. Is that clear enough?
Yes.
Brady, yeah, Brady means less or low. Tachy means increased. So these are all features, typical features of health conditions. So it will still suggest to you, okay, this patient is having bradycardia. That is now narrowing your guess or because you're trying to make diagnosis. There's what we call differential diagnosis, which is possible conditions. If it is not this, then it should be this. If it is not this, it should be this. So by the time you are trying to rule out so many conditions, there is no how any condition that falls if the BP of the patient is around 42 beats per minute. You shouldn't be thinking at all in any way. You shouldn't be thinking about any condition that has to do with tachycardia, that is increased heart rate. You should be thinking about bradycardia. Tachycardia can come with hypertension and all of those things, but bradycardia can come with, of course, it's hypotension and then with other, even physiologically, tachycardia can come, maybe the person is an athlete. The heart has to increase, heart rate has to increase to compensate for those activities. So all of those things put together, but however, it is going to help you narrow your intelligent guess. All right. So after this again, okay, this is the same thing I just explained down up there about the whole division, the counting of the boxes and all of those things. So that's different. That's the same thing I mean. Now, this is the picture of sinus bradycardia and sinus tachycardia. Now, remember the normal is what? Sinus reading. But the abnormal, which is normal.
Arrhythmia.
Yeah, arrhythmia is abnormal. Arrhythmia is abnormal. Arrhythmia is abnormal. So for it to be bradycardia or tachycardia, it means it is abnormal in general. Arrhythmia is a general term, you understand? But specifically, is it increased or reduced? That's when you go to what? Bradycardia or tachycardia. But both of them are what? Arrhythmia. Hope that's understood. Confusion.
Yes.
All right. So here we have for the sinus bradycardia again, to see it practically on your ECG. Bradycardia means there's reduced heart activity. And if there's reduced heart activity, okay, let me try to make it practical for you to understand. Remember, this is in voltage, this is in seconds, that's in time. So if after this is a whole cycle, this is another cycle, this is another cycle. I mean, heart cycle, that's pumping action itself. So what you see here in bradycardia, there's reduced heart activity. It means that it will take a longer time. This is time, remember, here. Going this way is time. So it means that it will take a longer time for the next activity to occur. Remember the normal boxes were what? 5 we counted, right? This is now what? 1, 2, 3, 4, 5, 6, 7. So it means that it will now take a longer time. This is one circle before the next circle. Well, let me write first since I have 1 and 2 up there. This is the first circle. Before the second circle comes, it will take up to 7 boxes, and the number is supposed to be 5, like we counted there. So if you want to make it practically, let's divide 300 by 7. If you have a calculator here, it's fine. Help us check. That should be around 40 something, right? Or 50 something.
42.
Okay, 42. Well, that was the
42.8.
example. Okay, 0.8. So you can see that this is below what the range I gave, which is below 60 to 100. Am I correct? Yes,
Yeah.
beats per minute. So this is still telling you that this is bradycardia, of course. So I just use the ECG, the boxes here to calculate 300 divided by 7 to see that it is still 42, and then that is reduced heart rate. So this is still suggesting that it is bradycardia. So this is very correct, that this is about bradycardia. You can see here again, you have 1, 2, 3, 4, 1, 2, 3, 4, 5, 6, 7. The same thing. 1, 2, 1, 2, 3, 4, 5, 6, 7, 8. In this case, it's even 8, so it should be lower. This should be 30 something. It should give us 30 something. So this is bradycardia for it. There's reduced heart rate. That was the definition of bradycardia I gave, if you remember. Now for tachycardia, that's sinus tachycardia. It is the opposite. This is the first cycle. This is the second cycle. This is the third cycle. And in between the cycle, you have just 1, 2 here. 1, 2. So if you divide your 300 by 2, you have what? 150. 300 divided by 2 is 150 beats per minute. And this is way higher than 100. This is even 50% increase already. So this is tachycardia. It means the heart is now racing. It is faster. So you shouldn't get confused because you are seeing this wide gap and then you think that's the tachycardia, and then you are seeing this short gap. You think it's the bradycardia. No, it is the opposite. By the time you bring this calculation into practice, you see that the value you get is what will suggest if it is tachycardia or bradycardia. All right, so okay, these are all things I've said so far. These are just written in text and all of those things. So this is still to calculate again on the actual ECG, and then you're checking the heart rate. This is another method, but I wouldn't want to disturb you different methods. This 13 times 6, which is giving you 78, which is um within that 60 to 8 200, I mean. So that's just by the way. So far you've understood that explanation I gave up there. It is okay and good enough. This is still the same thing. You are still calculating. These are just examples for you to calculate and find the the state of the heart rate, if it's bradycardia or it is tachycardia or if it is normal even. So that's it about the reading, the rates, I mean. Now we'll talk about each of these waves individually. Remember again, just to remind you, we have P, we have Q, we have R, we have S, and then we'll have T. So P, Q is here, R, S, T. This is just to remind you. So what we have here, you can see this red here is focused on the P. Well, whatever we're talking about is going to be on the P wave. It's going to be on the P wave. So let's start with the P wave here. By the time you pick your ECG graph, you confirm, are there P waves? Is it present? Yes. Is P wave followed by QRS complex? Yes. Yes. You know that you are dealing with an actual ECG, or the ECG, there's no error from the machine itself that's trying to produce that. So do the P waves look normal? Check the duration, direction, and shape, all of these things. Now you can see that, okay, this line here, there's a line here. Right? Let me call it the baseline. What is called in cardiology, it is called isoelectric line. So some of the waves you can see go above, which are positive. Some waves are what? Negative. This is another positive. This is another negative. This is another positive. So what you should notice, the waves that are positive on the normal ECG and the waves that are negative. But now you should know, because each time I label them, here we have Q and S are always negative. So if you find P, these are always negative side. This is positive side. If you find P, which is supposed to be positive, being negative, then there's an issue with the P wave. And the definition of P wave is what? Atrial depolarization. That means your concentration should be towards just the atrium of the heart. That's how these things help you to suggest, give you ideas about diagnosis. If the problem is about the Q wave, maybe it is not, there's no Q wave at all, or it is shorter, then you should start thinking of what the AV. You know, QRS itself is the atrial, is the ventricular depolarization. That's contraction of the ventricles. But the onset is to start from Q. Once the wave reaches Q, then it is trying to initiate that ventricular contraction. By the time it gets to Q, to R, I mean, it has gotten to the peak of that contraction. Then gradually S is trying to release the contraction. However, the whole of the QRS is still contraction, but these are just in different phases, maybe initial, peak or actual, then terminal. Then by the time it moves to this T wave, then it is being released for repolarization. So do the P waves look normal? Check the duration and direction. So the duration, yes, you check maybe the values, how many boxes. That's one of those things I mentioned earlier, but you can still, you don't need to cram the boxes. Once you see that it is abnormal compared to the other ones, it will be visible enough. But however, the one that will be most pronounced is the direction. This is in the actual direction. So this P wave is normal because it is in the positive side. It is in the positive side. So the direction, then, if P waves are absent, then are there any atrial activity? Those are all questions you ask yourself. But however, specifically concerning the P waves, if there is an abnormality on the P wave, now you can see that the P wave is 1 before the QRS. The P wave shouldn't be more than 1, or it shouldn't be absent. It should be 1, and it should be on the positive side. So if there's a deviation from this, then there are conditions, and there are features we use to describe this. We have the sawtooth baseline, we have the chaotic baseline. The sawtooth talks about atrial fibrillation, flutter, and then there's the atrial fibrillation. You must have heard this maybe during your internal medicine classes, but then this will give you a better view, both in the picture and then how you can imagine it occur in the heart. So when you hear sawtooth, there is this instrument, I mean, that this tool that those who repair or fix furniture, they use to cut wood. It is normally like this. And then maybe the handle is here. This is called a saw. This is a saw. Use it to cut wood, use it to cut some other things. So the sawtooth appearance, this is what the P wave will give you. It will be slanted a bit. It can be slanted a bit, I mean, and then it will be more than what you should have. So this P wave you can see is upright, but then any deviation from this makes it a pathology on the atrium, or the P wave relating to suggestive of the atrium. So back to what I was saying, the sawtooth means that there's what you call it the flutter waves, flutter. And then the chaotic comes from the word chaos. Chaos means there's problem, there's disaster, there's destruction. So the P wave that's supposed to be this way, it's now this way, it's now this way, it's now coming this way, and all of that. That's chaos. So that makes it fibrillation, atrial fibrillation of the P wave. And then if the P wave is not seen, it's just there on this flat line, that's isoelectric line. It is not moving towards the positive side, just straight. That means you can even see P wave is absent. That means there's no atrial activity. So let's look at this in the pictures. The first one I told you is what? Atrial flutter, the sawtooth appearance. This is the sawtooth appearance or pattern. And you can see the P wave is the one that follows the QRS always. So if you look at it here, it is looking like the saw. It is slanted, and it is more in number. Look at it, just like the saw. See, this one is 2 here. This one is 3 here. And all of those things. So just imagine the saw I just drew up there. This is what this picture is giving us. So by the time you pick your ECG and then you just see this, of course. In short, when you tell your teacher this, the person will be impressed with you, your teachers. They already know, although this is above, they'll consider this above your level, a little above your level, that you can just pick it and analyze it without any help. But however, it is good that you have the knowledge because, like I said, you use the knowledge outside clock, throughout your medical practice. As a student, if you want to be a teacher, the same thing. So for the flutter, for the fibrillation, this is flutter, we just finished here. For the fibrillation, like I told you, it is chaos. It is chaotic. There's no actual pattern, but it is not the normal pattern. So first of all, look at this P wave here. Look at this P wave here. Excuse me. The next session, there's nothing even. Then here again, it is looking different. You can see the difference between this and this. Then here again, then here it is looking almost flat again. Here it is very pronounced. There's just difference. There's just a different pattern of the P wave. It is not normal and it is alternating. So that is fibrillation, atrial fibrillation. Are we good with this too?
Yeah.
All right. So the same thing here. The sawtooth appearance is here for the flutter. The sawtooth appearance. So this is on the clearer ECG. There's a fibrillation here. Look at this P wave compared to this P wave compared to this. It's showing so many variations. Look at this again. The same fibrillation you have here. So that's just what you need to know. Then there are conditions to where you can have the P wave becoming wide or becoming shorter or still maintain its normal length. So if you still want to go practically down, the normal length, the length will go this way and it is in seconds. I don't mean length in seconds. I mean the direction is in seconds. It's in direction of time. So the time is supposed to be 0.12 seconds per P wave. So that P you have this way. If you count it on the box, it's supposed to be 0.12. However, it can be, yes, in brackets, it's three small boxes. That's why I told you from the onset, from the beginning, that you check if the ECG is calibrated. After checking the name, confirming the name of the patient and the date, you confirm if the ECG is calibrated. It's that calibration that will show you, okay, there is time here in seconds, and each second is this and this and this. This is calibration. You can see here. This is calibration, but on the y-axis. So that's what will be suggestive of what you are doing. You won't just see an ECG with this kind of okay, you can pick two ECG graphs. Let me give you another hint. You can pick two ECG graphs, and then you have one P wave like this, and then you have another P wave like this. Ideally, when you look at this, you just say, okay, this one is wider P wave. But it will be surprising or shocking to you that this is actually shorter. Now, what will help you determine that? By the time you check the calibration of that ECG, then that would help you determine if it is wider or shorter. If you pick a meter rule or a tape rule, it could be measured in inches or in centimeters or in meters. But if you just go by the estimation that this meter rule is very short, is very long, I mean, and then you don't go with the calibration on it, you might miss the whole concept there. So that's the sense, that's the aid of this calibration to tell you, okay, the calibration is actually in seconds and per box, this is what you have. So the ECG calibration will always come out this way. Each small box or three small box is 0. However, this is the standard 0.12 seconds. But in some ECG, these three small boxes is for this particular one. Some ECGs will be 5 small boxes for 0.12, or some will be 2 small boxes for 0.12. But however, the 0.2 is a standard second for the P wave. So that is the normal. So you should take note of these things too. Now, when you have a broad P wave, like I drew here, this is broad, this is wide. That's what it means. In the standard lead of 1, 2, or 3, or you have bifid P waves, then it is suggestive of LAH. LAH is left ventricular, left atrial, sorry, that's what I talk about P wave, so it's atrium. Left atrial hypertrophy. We also have the right atrial hypertrophy. Atrial hypertrophy. So first of all, let's look at the first one we have here, which is broad P wave and bifid P waves. Bifid, okay. Before I go down to the picture, so I want to go down, I won't have to scroll that far. If the P wave is wide, this is wide, first of all. And then bifid means you have two P waves. You're supposed to have one. Now you have two. Bi is two. So you have two P waves before you have your QRS complex. This is wide and bifid. This is suggestive of left atrial hypertrophy. If you have biphasic P waves in lead one with negative deflection more than the positive deflection, then that is right atrial. Now this is what it means. You know the P wave is supposed to go up. That's positive deflections on the positive side. But then if you have biphasic, first of all, and then you now have the negative deflecting, that's okay. The P wave, this P wave is supposed to be up, but now it is going down. Then before you have your, okay, it is going down, and then you have your QRS complex again. This P is supposed to be up ideally, but now it is down. So that is still a left atrial hypertrophy. And then another case scenario is where you have very tall P waves in the standard leads and then positive deflection more than the negative deflection in V1. This is relating to the V1, V1, V1. I'll still go back to the ECG up there and then you'll see the V1 I'm talking about. So now the P wave, which is supposed to be like this, is now this high, very tall P wave. And then you have a positive deflection more than the negative deflection. That's still the same thing. P wave is up there and then the negative deflection is now looking shorter. So quickly about those about those V1, V2, V3 you're talking about there. So when time you pick your ECG graph, this is what you look at. You have 1, 2, 3, you have AVR, AVL, AVF, you have V1, V2. So it is suggestive. You always make reference to this V1. This is the V1. This is the V1 here. So by the time you have all those abnormalities relating to the V1, if V1 is less than all those things, then you will make your inference that, okay, this is left atrial hypertrophy, this is right atrial hypertrophy, and all of that. So that's why we are making reference to the V1. How important is it? Well, I think that gives the V1 actually gives the most activity. Okay, this is the chest. This is the chest. Let me quickly draw this and paint a scenario, a quick one. This is the human, the neck, then this is of course not proportional, but then just to give you an idea how they place this. There's this chest lead. There are lead 1, 2. They start from here. I can't remember the actual. They have an anatomical landmark, which is I think second intercostal space on the right, but I can't remember the exact. Okay, right sternal border, second intercostal space. So that's why you fix that. So let me cancel this. This is the sternum. That's the bone in the middle of the chest. So on the second intercostal space on the right, you have 1. As you're coming down, you have 2, 3, 4, 5, 6 is on the apex of the heart. So it is believed that this first, that's V1, or the lead you place there, corresponds to, the heart is this way. The heart is this way, right? It is not straight, it is bent this way. It is believed that where this SA node is, coincides with where this V1 is. So by the time you place your chest lead there, that is where you have the maximum impulse. Remember even the impulse of the different conducting system, the SA node, AV node, that has the highest, which is up to 120 beats per minute. So the impulse is generated, which is the highest. That's why you make reference to all the other limbs in relation to the first V1, in relation to the V1, which is coinciding with the SA node. So that is just the reason why all the relations you are seeing there is to V1. All right. Okay, yeah, so that's what I just explained here. Everything is concerning V1. You can see V1 up there, you can see V1 here too. So those things have been drawn up there. This is another picture you have. For the normal one, you have in lead one, you have the normal P this way, or you can have the V1 this way. But then in right atrial extension or hypertrophy, then you have the bifid or towards negative, I think, yeah. Then here is also bifaced, then pointing towards negative 2. Then this is both right atrium and left atrium extension or hypertrophy. You have it wider. That's just the difference. You have it wider in these cases. So again, look at the ECG for you to understand. You have the P wave, which is normal. This is the normal P wave. But then for the top P wave, look at where this ends. For the normal P wave, this ends here. This is from here to here. This is the P wave, right? But for the top P wave, it is starting here, but then it is touching this line. It is extending up to this line. And then for the white P wave, instead of just here to here, or like I'm saying this normal here to here, here it is from here to here. In the normal, you have 1, 2, 3 boxes, and the white you have 1, 2, 3, 4 boxes. And then the white and by phase or by peaked. This is white, of course, 1 to 4 boxes covered, and then you have 2 peaks, 1, 2 peaks. So this is just to explain all of those terminologies on these pictures. All right. After the P wave, you have the Q wave. But in between the Q wave, which is Q is here, but then you have an interval. So that interval is that period where these waves move from, where this impulse, electrical impulse, move from each of these structures or segments or chambers of the heart. So PR interval here is as it is written. It is from the beginning of P wave here. It's an interval, of course, to the beginning of QRS. So in between P and Q, that's where you have the PR interval. The normal interval is 0.12 to 0.2 seconds. All of these are just to define what the PR interval is. And then anything greater than 0.2 means that there's a prolonged PR interval. So a question can be twisted, although not in Croc, but I'm just trying to help you understand this. A question can be, look at this last sentence, greater than 0.2 seconds is called prolonged PR interval. So greater than, if there's prolonged PR interval, what condition do you think? I don't mean condition, what state would the patient be in? Is anybody has any idea?
Hyper something or
Okay, yeah, okay, there's hyper something, of course, but that's not the actual state. Okay, so here it is. It is prolonged. Remember we talked about what? Arrhythmia. It is prolonged already. It means that it is not normal. The reading is not normal. And
yeah.
secondly, it is prolonged. So is it tachycardia or bradycardia? The state of the patient now. Because it is prolonged. Okay.
No, so it should be
It should
it
be.
takes more time, slower.
Okay, yeah.
So it is tacky.
No.
So
Brady.
it's
Brady.
Brady, yeah, I
Slow.
need
Yeah.
that.
So because it is prolonged, because I bet if you count the number of boxes, although this is still showing us 1, 2, 3, 4, but ideally, this is not the typical ECG. This is just printed, but we're seeing 4 here. But however, we've been told that it is prolonged. So if it is prolonged, PR, okay, if it is prolonged, sorry, yes, it should be suggestive of the bradycardia because you have the smaller boxes. You have more boxes, I mean, and then by the time you divide 300 by 8, it will give you a smaller number. So that's reduced heart rate. Anyway, that's just by the way. I'm just trying to bring back what we've done to revise here. So this PR is now prolonged, and then you can start thinking of, okay, the P is sinoatrial contraction. That is the atrium contracting, I mean. Now the ventricles contracting is what? Ventricular depolarization. So the PR interval should be an interval between the contraction of the atrium and contraction of the ventricles. So you can start thinking of, okay, maybe the structure is on the atrioventricular structures or septum. I'm just trying to help you understand this and then apply it to the general, to the normal concepts or normal happenings in the heart. But however, just know that when there's prolonged PR, then there's a big delay before the QRS complex will occur. So this will be the last aspect I'll touch, which is the kind of heart blocks we have. There's the first heart block, first degree. There's second degree. Even the second degree has type 1, 2, and then there's third degree. So about heart block, it is not a difficult terminology. It is not different. Heart block is heart block. It means that there's a blockage. There's no normal activity going on. So for the first degree heart block, the PR wave is fixed. Okay, first of all, so that you understand about this heart block, what we mean by this heart block. I think I'll need a clearer pitch. Yeah, I'll need a better pitch so that I'll draw this well. Okay. So let me just get this copied and then I'll bring it up here. So far we've done. Is there any question? Is there any confusion while this is loading?
No.
Okay. So, okay, this is heart block. So let me place it here. All right. So about the heart itself. If I draw the heart this way, as it is, slanted, there's the apex down there. Then I'll draw this, the atrium, right atrium, the right ventricle. This may complete the tricuspid valve. And then on this side, you have the bicuspid valve. You have the left ventricle and then the left atrium. So when we talk about the activity, first of all, there's a node here. there is another node here. And then from this node, okay, from this node, there are about 3. I've forgotten what they are called. I've honestly forgotten what they are called, but I need to remember. I'll text you if I remember. I'll message it. Then you have the bundle of his coming this way. Coming this way. Left and right bundle of his. Then you have the Purkinje fibers extending this way. So by so doing, up, 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 up. By so doing, the whole heart is getting that impulse. Now, what happens during the generation of impulse? Here it is. The SA node, like I said, will be the one to generate. It is self-generating. SA is sinoatrial, of course. SA node, and then we'll have AV node. Now, this SA node will generate the impulse and then send it to the AV node. The AV node will collect the impulse and then send. Now, this SA node, while it is generating the impulse, it is contracting the atrium because it is around the atrium already. So in order to transfer it to the ventricle down, this AV node will receive the impulse, and then transfer it through this bundle of his, and then it will start initiating that contraction of the ventricles, and then through the Purkinje fibers extending, then there'll be full contraction. So that's what happens. It's an electric impulse. Now, why is this AV node important? You can ask, maybe if this SA node generates, why doesn't it just transfer down directly to because the power, remember I told you, the energy, the pressure is up to 120 beats per minute, and that is for the atrium. The whole heart doesn't need that much pressure. There is a beats per minute, sorry, millimeter of mercury. It doesn't need that much generation of electrical impulse. So then it needs towards the AV node will then receive it first, so that the power won't just come. It will stop it first and then try to release it gradually into the ventricles. So the AV node causes a delay and a blockage. Delay and blockage. Delay so that what will happen? First of all, I told you the contraction happens in the atria, and then the ventricles will wait. So when the atria is done contracting, then the ventricles will contract. So that delay, that period where the AV node receives electric impulse from the SA node, it will delay the impulse first and wait for the atria to finish contracting. So after the contraction, then it will release it through the ventricle, through the bundle of his, through the ventricles, and then the ventricles will then contract. So the AV node will cause a delay and to cause that blockage. Now the blockage could be almost permanent. I don't mean permanent, it could be more than the expected duration of time. So that means there's delay of passage of that impulse to the ventricles. That's what we talk about degree of heart block. That is heart blockage. So that is the idea about heart blockage. Now, going back to this, there's the first degree, like I said, of heart block. There's a second degree, there's third degree. Second degree has type 1, type 2. But the first and third is just first and third. There's no type. So in the first degree, going by the concept of just seeing up there, it involves a fixed prolonged PR interval. Fixed prolonged PR interval. Bringing it down to practice again. Contraction of this atrium is what's the P, right? Then the QRS is the contraction of the ventricles. So if you are seeing that there's a delay between this P and this R, this PR interval, that means the delay is within this place because there is an actual contraction of the atrium, but then there is a delay in the contraction of the ventricles. So that's why the delay, of course, like I said, is caused by this AV node. So going by this definition here, the first degree heart block involves a fixed prolonged PR interval, and then this first degree block occurs when there is now AV conduction, which is normal AV conduction, which is slightly prolonged. So the AV itself is prolonged. That's the AV node itself will prolong this impulse, and then it will then release it. So that's the first degree heart block. And in most cases, it's supposed to be normal. It's not really a condition because yes, that's the duty, that's the job of the AV node. But however, it depends on the length and some other things again that come in. Then that's what makes it a pathology. If the length is too, if it takes too long and all of those things. Now, we're done with first degree now. For the second degree, we have type 1, type 2. Type 1 is Mobitz type 1, or this. It's actually Mobitz type 1 and Mobitz type 2. Yeah, it's both Mobitz type 1. It's just the name of the person that discovered this. That's Mobitz. But then it is Mobitz or Wenkenbach. I don't know if it's his second name or it's a joint project with this other person. But then it could be Mobitz type 1 or Mobitz type 2. We'll see more of Mobitz type 1. We'll see more of Mobitz, the second degree heart block, in our core questions too. So however, I just need to understand from here too. So what happens is that there is progressive prolongation of PR interval. Now here, this progression is what? It's not progressive. It is the same. There's prolongation, but it's the same. The prolongation, okay, if the PR interval is supposed to be 0.2, I said it up there. But in first degree, it is now what? Because there's prolongation, it means that it is greater than 0.2 seconds, right? That's what it means. Now, the prolongation in first degree is not changed. It is the same. So if it is going to be 0. Let's say 24, the next PR interval will still be 0.24. The next will still be 0.24. There's no change. It is the same. That's the prolongation. Yes, it is prolonged. It is more than 0.2 seconds, but it is still the same for each cycle. But however, in type 1, there is subsequent increase. Now, this increase, you can see the normal is 0.2, but here you have 0.21. It has increased, and it has increased further to 0.22, and it has increased further to 0.24. The increase is more and more and more. So this increase occurs until eventually the atrial impulse is not conducted and the QRS complex is dropped. Of course, that prolongation is too long, but after the first cycle, there was prolongation. The second cycle, there was more prolongation. The third cycle, more and more prolongation until the QRS doesn't even occur again because the atrium needs to contract again. It will wait for the QRS to contract. That's the ventricles to contract. But once the time has elapsed, because of that long prolongation, the QRS has not contracted, but the atrium needs to contract again. So the atrium will then go back and contract again without waiting for the ventricles to contract. And then that's why they said what? There is a drop in QRS. So on the ECG, you will see that there's an absent QRS at a point. So that's the type 1. So here it is in the picture. This is the PR. There's progressive. This is increase first. Then there's more increase here. Then there is more increase here. That this atrium cannot wait for the QRS to occur because of the long prolongation. And then after this, it drops, the QRS drops. It doesn't even occur again, you can see. Then maybe after some time, it will don't pick up again and start. So that's the type 1 Mobitz. We're talking about second degree, of course, that's type 1. In type 2 now, there's also, okay, this, yeah, Mobitz type 2. The ECG findings include a consistent PR interval duration with intermittent drop of QRS complex due to a failure of conduction. So in this case now, okay, this consistent PR interval duration is there first of all, just like similar to type 1, I mean. There's that consistent prolongation. But then there's that intermittent dropping. It doesn't wait, in type 2, it will be increasing gradually from 0.21 to 0.22 to 0.23, and then eventually to drop. But here, from 0.21 it can drop and then continue from 0.22, 0.23, drop again, then continue 0.24. That is the difference here in type 2, second degree. This can be a bit confusing, but well, that's just how we need to understand this, the second degree. And ECG, like we're always told, if you leave ECG, it will leave you also, just like in mathematics. Although you are not training to be specialists in cardiology, but eventually, at a point, you need to use this for exams, whichever exams you are going to write. So for the third degree, okay, this is Mobis type 2 again, type 1 compared to type 2. So this is the normal one here you have. And then in type 1, you have this prolongation here, and then more prolongation before the drop. There's no QRS complex you can see here. However, here, this is prolongation. The absence occurred here. This is another prolongation, absence occurred here. So that's what I just explained, differentiating the type 1 from type 2. So the last one, which is third degree heart block, this is called complete heart block, the third degree, just like how you stage cancer. Stage 1 is actually mild in a way, stage 2, stage 3, stage 4 is the end stage cancer normally. So this is a complete heart block. This occurs when there is no electrical communication between the atria and the ventricles due to complete failure of conduction. That means that blockage occurring at the AV node has occurred completely. It is just blocking, and then there's no passage of impulse down to the ventricles. So these ECG findings include presence of P waves and QRS complexes that have no association with each other due to the atria and ventricles functioning independently. Now, why are they functioning independently? Yes, I told you that the SA node generates the impulse. The SA node generates the impulse, but then other impulses too can be generated. This is a way that the body compensates. This is like a compensatory activity. So, but remember the interval I gave? I think it's, okay, this is actually 80 to 120. 80 to 120. So this is 59 to, no, 60 to 79. Am I correct? Yeah, thereabouts. No, not 60 to 59. Not 60 to 70, I mean. Is 60 to 79. Then for the bundle of his, they also generate their impulse. Bundle of his generate their impulse, which is around 39 to 59. Then the Purkinje fiber also have theirs, which is less than 20. Less than 20. Thereabout. This is just a rough sketch. I'm just trying to give you an idea. So what I mean by this is that, yes, the SA node generates the actual impulse, but then the other structures, so in case the SA node fails or the atrium has a problem, then to compensate, because like I said, the heart is very delicate. If the heart is gone, every other organ shuts down, and that leads to death. So this has these other alternatives, the other three alternatives. If the SA fails, then the AV can then pick up, but its own generation is maximum is 79 pressure, that's millimeter of mercury. If that one too also fails, the bundle of his can pick up, its own maximum is 59, and that's how you see it. So that is why if there's complete blockage there's no electrical activity, first of all, and then there's no communication between the atrium and the ventricles. It means that that generation of the SA node or the electrical impulse by the SA node is only carried out around the atrium. Now the ventricles would then need to start depending on themselves. Take, for example, an orphan. He was depending on his parents and all of that. All of a sudden, he lost both parents, and then he becomes an orphan. So becoming an orphan means that he has to fend for himself. He has to source for livelihood, for both food and if it's education, money in general, and food. So that is the same thing. The SA node doesn't really, why? Because there's now blockage there. The ventricles will then try to generate their own impulse, which is with the help of bundle of his, first of all, before the Purkinje fiber. So that is why they are they've lost communication, and then they are now on their own. So the QRS complex have no association with each other. That's the P waves and the QRS complex have no association with each other due to atrioventricular functioning independently. Now they're independent of each other. So what you have here is you have the P wave. You have the P wave here, way far away from the QRS. QRS is here. Then you have another P somewhere here. There's that long delay. QRS is here again. P is around here. There's another P. It doesn't wait for Q to occur. It just occurs on its own. That's why there's absence of Q. QRS. Then there's another QRS here and all of that. This is just the difference here. So all of this are what you pick in the ECG, and then you differentiate. So all what I've said, these are the explanations, of course. Look at that's what I said. In Mobis type 2, after the AV node in the bundle of his of Purkinje fibers has occurred also. So basically that is it. That is it about the ECG. The other things are just added notes. I'm just adding it for the sake of knowledge and information. But however, okay, let me talk about Parkinson-White syndrome, because it is in core questions normally, which is this. So this Wolff Parkinson-White syndrome is a short PR. Now we talk about PR being long, that means there's a delay. Now in this short PR, it means that what? The QRS complex will occur, the QRS complex will receive the impulse earlier than expected, and then the ventricles will contract earlier. Maybe the atrium is not done contracting, and then the ventricles will then start contracting. So that's in Wolff Parkinson-White syndrome. So there's short PR, that's less than 0.12, and then you can have delta waves or slot wave. Delta is D. Delta, where did I say delta again? Well, this is what you have if it's clock. You'll be asked what kind of wave can you see in Wolff Parkinson-White. So it is delta wave. Take note of this. Take note of this. So the delta, delta is a shape. This is delta in physics. So this is a shape, although it is not clear enough here. It's giving that delta shape. Yes, you think it is normal. You see it like it looks normal, like the normal QRS complex, but the QRS comes this is QRS this way. But then this extension, there's no extension of this Q wave. That's why you can see that here is short, here is short, here is short, making it equal with this line, isoelectric line. Here too is short, here is short. So making it more delta. Like I said, this is delta shape here you have. This is delta shape. So that is what you have in Wolff Parkinson-White. Of course, Krog will not ask you to interpret ECGs this way, but all the small findings you'll have. Okay, what kind of wave do you find in Wolff Parkinson-White syndrome? This is delta wave. So that's what I want to talk about in Wolff Parkinson-White syndrome, basically. All right, any question?
No, thank you.
All right, you're welcome. So that will be till Friday, till Saturday, I mean, next Saturday, before we continue with the normal crop classes. Yeah.
All right. Have a good day.
Yeah, you too.
Bye.
Please. Yeah, goodbye. Hala. Still recording?
Yes.
Okay, yes, you can end it now, please.
Okay.
Yes, I'm forward on Telegram. Thank you.
You're welcome.
Yeah, have a good day all.
You too. Thank you so much.